So again, as we continue to go through historical methods, looking at what Dr. Still has noted about ribs, we have descriptions from section 307 and 308 in Osteopathy Research and Practice. One of the things that we're going to run into here is that the description that is utilized by Dr. Still for his first methodology with ribs, there's a high likelihood that the way that it was written is not communicating what he did in as accurate a way as possible, and this is a problem with the nature of writing descriptions out for these methods. So he talks about doing this against a door jamb. Now, again, the door jamb is so that there's nothing behind the ribs when you palpate behind, but the patient is standing. He says, take the right arm in your right hand, reach around through the armpit and the axilla, right? So basically you're reaching around to identify the ribs, and you can mobilize off the arm, right? So you can use the serratus anterior, you can use some of the pull of the other scapular muscles, you can use pull from the pectoral muscles to mobilize the ribs. However, what he does talk about is, in doing this, trying to stabilize with your shoulder, right? So here, this becomes very awkward, right? I can't clear any space. So when Dr. Still talks about stabilizing the sternum with your shoulder, it likely doesn't accurately reflect what he would have actually done, because it's a very awkward thing to attempt to do, because your arms won't move appropriately while keeping your shoulder against the patient's sternum. What you may end up seeing, however, is I can be here, I can place the patient's arm on my shoulder, stabilize the sternum with my forearm, reach behind, and now I can move to some degree, but a large amount of the motion that I'm going to feel, because I won't get much tension off of his shoulder or off of his scapular muscles as they relate to the ribs, what I'm going to feel is me moving. So as I move this way, I move in relation to him. I get some pull on my fingers, so I can think that that's ribs moving, but it's me moving, right? So if you watch it, we both wiggle, right? Then you can be like, oh, well, his ribs moved. Well, they probably didn't, because I didn't stabilize them the way that I thought I would. So the idea being here, you know, even whether it's on a door jamb or not, I can use tension to mobilize the ribs. Now, because he's standing and because I can't necessarily stabilize him, it may be intelligent for me to have somebody else stabilize him, or I can use the concept of patient positioning and consider that the table makes stable. So that might actually work as a concept slightly better in supine or in lateral. So if he was in supine on his back, the table would stabilize him. Half of him is in contact with the table, I don't have to worry about it. If I put him in lateral, I would be behind him and keep him close, and then I could stabilize him, move his arm, and pin the ribs. So this would likely, these concepts would likely work better in supine or in lateral, but that's just to attempt to show that the description that Still gives probably doesn't accurately reflect what he would do or how he would do it, but it was an attempt. The second description will have you flip and face the other way. So he basically uses the concept, right? So turn your head one way so that you can actually put your chest against it, right? He uses the concept of stability, or I can describe it as, you know, table makes stable, so now the wall makes stable. And he just talks about, he doesn't say one hand or two hands. He basically says push against the ribs until you find the offending ones, push up or down, right? So I could push with two hands and identify, right? So broad contact for multi-point discrimination, I can use a large contact to identify and just push in, right? And then I could just push, I could wait, I could use activating forces to turn on around so that you're not stuck against the wall. But essentially he talks about using the arm and muscles that relate from between the arm to the ribs to create tension, relational motion, so you're trying to keep the ribs relatively still, and then use the arm moving in relation to it to build that tension. I would suggest that that would work better in supine or lateral, and then essentially using the wall and standing patient to recreate a prone position whereby the wall does the stabilization, or in the case of a door jamb, the door jamb gives the stabilization. So the patient would have to tuck their head away from the door jamb, otherwise, you know, they won't get their chest against it. But then you can push and get some mobility on either side of the door jamb. Again, you're looking at relational motion, you're looking at the concepts of patient positioning. So this is an attempt to show the description, and also note that the way that at least the initial description in section 307 was written, probably not accurately reflecting what Dr. Still was doing.